Welcome to the Bariatric Information session. This video brings together educational clips taken from our Bariatric Information webinars that ABL Health created in collaboration with Salford Royal Hospital. You'll hear from a range of experts on the Tier 4 weight management team sharing their knowledge and guidance about bariatric surgery itself, what the diet looks like pre and post surgery, how to reduce risk of weight regain, and how medication intake might differ after surgery. We'd also like to share a heartfelt thank you to Jodi, the bariatric nurse at Salford, whose commitment and coordination made it possible to bring these voices together.
So my name's Chris Grocott. I'm an upper GI surgeon and I work for the NHS at Salford. And my subspeciality interest, I'm an upper GI surgeon, and along with all of the bariatric surgeons at Salford, I do both cancer and bariatric work. So about every 6 months, we're asked to do this education session and essentially go through the surgical options. Just trying to get my slides to advance. Okay. So the things I'm going to talk about tonight are the surgical options available, the advantages and disadvantages of each, how we choose which procedure to use for each individual patient, all the factors that influence that decision making. I'm briefly going to touch on consent, and then I'm hoping that the bulk of the session is going to focus on discussion and questions. So, as Jodi said, there are essentially three choices. Now, if we were to simplify that further, increasingly, we're essentially offering sleeves and bypasses. There are two types of bypass: the Roux-en-Y gastric bypass, which you can see in the central picture, and the mini bypass. Other names for the mini are the single anastomosis gastric bypass or the one anastomosis gastric bypass. And essentially that is a newer variant of the Roux-en-Y gastric bypass. In many ways, results seem to be very similar or even better, but there's slightly less follow-up. So we'll touch more on that as we go through the slides. So if you like, the entry-level bariatric procedure is the sleeve gastrectomy. It's got significant advantages. The main thing from my point of view is I think it's a very simple, straightforward operation. And essentially we tubularize the stomach. So you can see that we divide the stomach longitudinally, and we're left with a banana-shaped stomach. And obviously the storage capacity is massively reduced. It's simple, it's very effective, and we see patients lose approximately, or the average patient lose approximately 60% of their excess weight. So if we were to talk about excess weight, that is essentially the difference between a patient's starting weight and the natural healthy weight. So in a patient where that excess is 10 stones, we would expect them to lose roughly 6 stones in weight. It's a restrictive operation, and by that I mean it reduces or restricts the amount that any patient is able to eat post-operatively. It's got relatively minimal physiological impact in that the food or medications that you take in the future still go all the way through your gastrointestinal tract from your mouth to your anus without interruption. And the other thing that is an advantage to it is it essentially gives us more options for the future if reoperative surgery were ever required. And that's one reason why we tend to recommend sleeves in younger patients. But again, I'll touch on that again as we go through. So disadvantages of a sleeve. I mean, in some ways, this is it goes for all bariatric operations. I think you've got to go into bariatric surgery expecting it to change your eating pattern for the rest of your life. And you need to think about the implications of that. So we sometimes meet people that socialise as part of the job. For example, they have to entertain in the evenings as part of the working life, take clients out for dinner, etc. So bariatric surgery is going to affect your ability to do that. It also seems to reduce alcohol tolerance. And so patients need to go into surgery, obviously well informed, well educated, and to have thought through all of the implications for the life going forward so that they get best possible result. Now, the only real disadvantage to sleeves is that about 10% of patients afterwards end up with reflux. And the reason why we see reflux in a sleeve, we can think that we start off with a relatively wide, relatively low pressure bag, i.e. the stomach, and then we form it into a much more narrow and a much more high pressure tube. And so that makes it that little bit more difficult for food to go down and through. It makes it easier for any gastric acid to come back up. So we see approximately 10% of patients report reflux after a sleeve that don't report it before. And that can be associated with reflux-associated changes of the cells at the bottom of the esophagus that we call Barrett's esophagus. The one other thing to say about a sleeve is part of the stomach that's disconnected that we can see on the right-hand side of the image here, that's removed from body, and that's obviously irreversible. Because of the association with reflux, with people who have reflux preoperatively, we try and avoid sleeve gastrectomies. Now that brings us on to Roux-en-Y gastric bypass. If we look at the shape of the bowel in the centre of the image, we can see with the eye of faith that potentially the way the bowel is formulated, we end up with a Y shape, which is where the name comes from. Again, very effective in anything, if anything, slightly more effective than a sleeve gastrectomy in terms of weight loss. Different studies report different results, but on average, we would often quote 65% excess weight loss. So somewhere between 60 and 70% in most studies. It works in two different ways. It's both got a restrictive element. You can see that at the top, there's the gastric pouch, which is disconnected from the rest of the stomach. So that essentially gives a very small gastric capacity, and then the small bowel is brought up and joined onto that gastric pouch. So there's the restrictive element from the gastric pouch, and then the food that's ingested, if we follow the red arrow downwards from the esophagus into the gastric pouch, it then comes into the small bowel, and we can see that the rest of the stomach and the area where the green arrows are, that piece of stomach and bowel is essentially bypassed, again, hence the name. Roux-en-Y gastric bypass has been around longer than either of the other operations. That means it's got the greatest evidence base supporting it. Latest studies show it to be more effective and potentially to offer a better post-operative quality of life than sleeve gastrectomy. The one thing that does push us towards a bypass is for diabetic patients. Now, in terms of disadvantages, everything in medicine and everything in surgery is essentially a balance of risks. And when we choose a particular operation for a particular person, what we're trying to do is we're trying to balance those risks and benefits for each individual patient. With a Roux-en-Y gastric bypass, slightly more complicated procedure certainly than a sleeve gastrectomy. And that means it's got slightly higher risks, both short and longer term. We tend to avoid it in people who've got significant history of bowel disease. And by that, I really mean ulcerative colitis or Crohn's, people that have previous major bowel surgery. And that's often because of the degree of adhesions that we would expect to find within the abdomen after major surgery. We obviously need the small bowel to be relatively adhesion-free to easily bring it up to the top of the stomach, which is essentially behind the breastbone. Finally, we tend to avoid it in smokers, and the reason for that is we both see an increased rate of leakage post-operatively in smokers, but also we see chronic ulceration at the join between the small bowel and the gastric pouch. Now, the mini or the one anastomosis gastric bypass, relative new kid on the block, been around between 5 and 10 years, seems to be very effective. at least as effective as Roux-en-Y gastric bypass. From a technical point of view, slightly easier to perform. Again, it gives us the advantage, but we see from a Roux-en-Y gastric bypass in diabetics, but we need to make sure that we avoid it in reflux. The reason for that is you can imagine the bile and the pancreatic juices coming down from the gastric remnant and essentially will have relatively high volumes of bile and pancreatic juice moving past the anastomosis on a daily basis. So we try and make the pouch that little bit longer, but reflux post-operatively is one of the complications. Now, the only real concern, I think, with one anastomosis is it's just not been around as long. So it would be safe to say that Roux-en-Y gastric bypass is still probably seen as the gold standard, and it's the operation that we compare all other bariatric operations against. So next slide, we're going to just have a think about some of the things that make us favour a sleeve in a particular patient or perhaps favour a bypass. The real advantages of a sleeve, as I would see it, is that it's simple. The risks are relatively low. It's simpler for patients that are taking a lot of medication. And the reason for that is all the drugs would then still go through all parts of the gastrointestinal tract. So absorption would be relatively unaffected. It's a better operation for people that are likely to have a complex abdomen, so people that have had a lot of previous surgery or people with big hernias that contain bowel. Again, I think I've already said we tend to use a sleeve in younger patients, and it gives us more options if preoperative surgery were ever required. For the vast majority of patients that come, a sleeve fulfills their weight loss requirements. And by that, I'm thinking people that come with a BMI of 35 with a comorbidity or somewhere between 40 and 50, a sleeve will essentially fulfill the weight loss goals. I think once people's BMI is 50s and beyond, then that's really the group that might get more benefit from a bypass. Sometimes with extremely heavy patients, so BMI of 60, 65, 70, we sometimes use either a sleeve or drug therapy to try and bring people's BMI into a safer range before we operate. So sometimes we use a sleeve to do that, sometimes we use medication. As I've said before, we particularly use bypasses in diabetics. There's very strong evidence that more diabetics stay diabetes free long term after a bypass compared to a sleeve. And we also can use a bypass in people with a history of reflux. And when I say use a bypass, I really there mean Roux-en-Y rather than single anastomosis. Now, the things that I tend to mention when I'm consenting a patient, I appreciate there's a lot of information on the slide, but I'll just highlight the key areas. And again, I would think of the two operations as the narrow, higher pressure tube of a sleeve, and then the lower pressure of a bypass, but obviously the food doesn't go through all parts of the bowel. So that's the two main differences. And as we go through the risks of the operation, a lot of it will be obviously related to those two issues. So with a sleeve, we remove about 2/3 of the stomach, changes your ability to eat for the rest of your life, 60% excess weight loss, normally in hospital for a night, and complications are possible, but they're very rare. Now, at the bottom of the second column, I've put on here death rate somewhere between 1 in 1,000 and 1 in 6,000. Now, the reason why I've mentioned that isn't to scare anybody, but there is some risk associated to all procedures. And if we think of, for example, laparoscopic cholecystectomy, if we go to the national data, the mortality rate or death rate from having gallbladder surgery is approximately 1 in 4 or 1 in 5,000. So that you can see that bariatric surgery actually compares pretty favourably with cholecystectomy. So that should hopefully give some sort of perspective to the rest of what I'm going to say. Now, the other things that we can see, there are risks associated with any operation, and I would summarise those as bleeding and infection, anaesthetic risks, clots, problems with wounds. The wound problems are normally just bruising. In terms of clots, we have a very careful protocol, and essentially we're balancing control of bleeding at the time of surgery versus the risk of forming a clot. What I do in my practice is we use Flowtron boots throughout the operation, and we pay particular attention to both the port sites and the gastric staple line when we form a sleeve to make sure we get perfect hemostasis. We deliberately push your blood pressure up during the operation so that if there is any oozing from the gastric staple line, we see it at time of the operation. We make sure that everything is fully under control, and that essentially finishes the operation. As we're closing up the skin, the anaesthetist is giving you your first injection of low molecular weight heparin. And using that protocol, I've not had any clots in my patients so far. So what we do works. Essentially, all of the predictable risks we have a contingency plan for so that we drive things to an absolute minimum. Now, the things that we commonly see after a sleeve gastrectomy is patients post-operatively on the day post-op or day of surgery tend to be nauseated. And again, that's because the stomach is relatively low pressure before surgery and it is relatively smaller and relatively higher pressure post-surgery. I've put reflux on the slide. Again, that's a longer term risk. We've mentioned that previously. But the two main risks we can see after either sleeve or bypass, one is hematoma, so a blood clot within the abdomen, and the other one is a leak. Both of those risks are in the region of 1 in 100. The reason they're important, I've put them on the slide, is they often need a return to theatre and a readmission. Sometimes after leaks, it can take weeks and weeks to settle a leak down. And so that's probably the most feared complication in the immediate post-op period after any bariatric operation. We occasionally see people that struggle to transition from liquids onto solids after a sleeve. That can be a structural thing, such as a hiatus hernia. And so if we identify a hiatus hernia at time of surgery, we tend to repair it if we're going to go on to do a sleeve. But sometimes, even if everything anatomically looks perfect, some people's esophagus doesn't pump as hard as the average person. And so some patients struggle to transition to more normal foods because of the higher pressure within the gastric tube. In the longer term, we see relatively few problems with multivitamins, although we do recommend annual blood monitoring for life. We've mentioned changes in the cells at the bottom of the esophagus. Whenever there's rapid weight loss, we do see sometimes development of gallstones, and obviously with rapid weight loss, we can end up with some loose skin. What we typically see is patients lose 50 to 60% of their excess weight over the first 12 months. The weight loss eventually plateaus off, and essentially, as it starts to plateau, patients can increase the amount that they exercise as the weight comes down and maintain the weight loss. Sometimes things will eventually plateau, and we often see some slight weight regain. Finally, with all patients that have a sleeve nationally, about 1 in 30 or 3% goes on to have a second operation. After a sleeve, the main indication for that is normally intractable reflux. So finally, I'm just going to talk about bypass. The general risks, exactly the same. The differences really are to do with the bypass element of either a Roux-en-Y or a Roux anastomosis gastric bypass. So you can see that the reflux rate, if we look at column 2, is far lower. It's 1% rather than 10%. And that's because a bypass leaves us with a low pressure system rather than a high pressure system. So the forces driving any gastric juices back into the esophagus are far lower. We can still get both blood clots or leaks in exactly the same way as we can after a sleeve. And we also sometimes see problems with eating. Now, the real difference, as I would see it in risk between a sleeve and a bypass is really over the longer term. Because a proportion of the bowel has been bypassed, we see more abnormalities in terms of blood changes. So people need to be far stricter with multivitamins and B12. And it's important to have annual blood testing so that we pick up any abnormalities and correct them. One of the reasons we avoid bypasses in smokers is that smoking is associated with significant ulceration at the anastomosis, and that can either be a partial thickness ulcer that bleeds, or it can be a full thickness ulcer which needs major surgery to correct. We occasionally see growth of bacteria within the part of the small bowel that's been bypassed. Gallstones and loose skin, the same really as after a sleeve. One of the complications after a bypass is internal herniation, and we don't see that after a sleeve gastrectomy because we don't leave potential spaces for that hernia. In terms of other issues, weight regain and future reoperation are essentially the same. And that was really all I wanted to say.
Tonight, we will be talking about bariatric surgery. My name is Bilal Al-Kafaf. I am a consultant surgeon based over at Salford Royal, and we'll be talking about not only bariatric surgery, we'll give a little overview on obesity, how it develops, what it is exactly, why it's so important to treat. And then we'll also spend a little bit of time talking about some of the fears that people have in relation to bariatric surgery. The majority of the evening is going to be spent answering your questions. So if you do have any questions for me, make sure you put them in the Q&A section so Stevie can monitor those throughout the talk. And I'll try and answer as many of these as possible. Usually that part of the session can go on for a long time, but we'll try and answer as many of your questions as we possibly can. Right, so obesity and its impacts we'll be talking about, the NHS treatment options, so the options that are specifically provided and are undertaken by us at Salford Royal in the NHS setting. We'll talk about those, the biggest fears, and of course the questions. So obesity is the excessive accumulation of fat, which importantly poses a risk to your health. Now, we know that obesity is linked and associated to well over 200 medical conditions. We'll talk about some of those now. We also know that our understanding of obesity has changed significantly over the last 10, 20 years. We now recognize it as a chronic, relapsing, and progressive condition. What that means is it doesn't happen overnight. It is something that happens gradually often over many years. And even if you have control over your weight, there's a possibility that weight can come back on later on in life. And that's a really important consideration when it comes to understanding the condition of obesity, because it also impacts on our understanding of how some of these treatments work, which we'll touch upon shortly. Obesity affects approximately 1 in 4 adults in the UK, and 2/3 of people either have obesity or are overweight. Now, more worryingly, about 1 in 4 children under the age of 15 are either obese or fulfill the criteria of being overweight. So this isn't a problem that's going to go away anytime soon. There are wider social implications. So we know that the direct costs as a result of obesity to the National Health Service is around £6 billion every single year. And if we then begin to explore some of the wider implications on society, when we look at sick days and some of these other factors, the impact on the wider economy, we're probably talking of an estimate around £30 billion every single year. So it's really important, not just from a financial perspective, but from a wider social implication, that we try to prevent obesity. And then, of course, those who have developed obesity, we try and help people out and try to help them control their weight and reverse many of the medical conditions we'll be talking about shortly. So obesity harms health on an individual basis. We've touched upon the fact that it is associated with over 200 weight-related medical conditions. Some of these are on screen in front of you. So if we look at these: heart disease, liver disease, stroke, asthma, back pain, sleep apnea. It also affects your mental health, so depression and anxiety and some other mental health disorders are directly linked to obesity. We also know that cancer is linked to obesity. There are 13 types of cancer and probably a lot more that are directly linked to obesity. And in some instances, for example, endometrial cancer, if we treat obesity, a lot of the time, endometrial cancer, certainly the precancerous cells, can go into remission and not actually progress into cancer. And that is some of the work that has been done by our very own colleagues in gynecology and in women's health here in Manchester. You heard Holly Baker-Rand already this evening talk briefly about some of the studies that we're doing. So these are very, very important associations that we are actively involved in researching as we speak. We've talked about some of the financial implications on wider society, and we've talked about the individual medical issues that obesity is linked with. But the reality is that there is also a lot of stigma associated with obesity, and this therefore impacts on the quality of life and the social aspects on an individual basis. We know that people who struggle with their weight are less likely to be in employment, but also can be passed up on opportunities at work as well. We know that people with obesity face widespread discrimination and stigmatization, and these are added reasons for us to really try and treat obesity as best as we can. Let's now move on to the treatment options. In broad terms, there are four considerations when we talk about how we treat obesity. All of these options, certainly when it comes to invasive treatments or medical treatments, must be accompanied with the commitment by the individual to engage in lifestyle changes, changes to nutrition, changes in physical activity levels. And we'll talk about that briefly in due course and in the Q&A session. When I speak to patients in clinic, I will always tell them that the first option that they have is that they do nothing at all. And why is that important? Well, everyone needs to understand their options, the pros and cons of each of the different treatment options, including the option of doing nothing. Now, that is the only option that's going to completely avoid the very small risks associated with some of these treatments. However, there is a consequence and there is an implication of doing nothing, which is that a lot of the medical conditions that people may already have can get worse. And of course, if you don't have medical conditions related to obesity, these can develop. That's why when we talk to people in clinic, we also spend a lot of time talking to them about their family history, understanding some of the diseases that run in the family. And that's something, again, we can talk about later. When we discuss treatment options in clinic, broadly speaking, there are the medical weight management options, which involve some of the new injectable medications that have been out on the market over the last couple of years. There are endoscopic treatments available, which include the gastric balloon and some newer novel treatments, including the endoscopic sleeve gastroplasty, which involves us using a camera and sutures or stitches, internal stitches, to make the stomach smaller. That's something that is still being developed and has been adopted by NICE, which is the National Institute of Health and Clinical Excellence, as an NHS treatment, but not very many centres are providing or offering that. Where we certainly focus our treatment options at Salford is in the surgical side of things. And we'll be talking more about the surgical options in the next few minutes. Before we touch upon that, let's talk about the eligibility criteria, because that's really important. Traditionally, the eligibility criteria have focused primarily on this calculation called the body mass index. The BMI, or body mass index, is a calculation which takes into account your weight in relation to your height. In an ideal world, a healthy BMI should be anywhere between 18.5 and 25. If you have a BMI of greater than 40, then you are automatically eligible for bariatric surgery. If you have a BMI of 35 with a medical condition associated with obesity, which would benefit from treatment, then you are eligible. And there are certain circumstances, for example, if you have new onset diabetes in the last 5 to 10 years, then your eligibility criteria is reduced. And further still, it can be reduced if your ethnic background is of South Asian origin, as we know that the risk of developing these serious obesity-related health conditions such as type 2 diabetes occur at a much lower level in that patient population. However, these are the traditional established guidelines, when in reality, these guidelines are moving sands. We have had over the last 12 to 18 months new guidelines from international consensus groups and international associations, which suggest that actually bariatric surgery can be considered and is safe at a much lower body mass index. So we've all heard these stories of people going abroad or people being turned away and saying, actually, you're not heavy enough. Well, we think that that is absolutely absurd. People who are BMI of 34 and being told, sorry, you don't fulfill the criteria, even though we know from their past medical history that that weight has severely impacted not just on physical, but also their mental health. It's, to me, certainly it's absurd that we would turn somebody away when we have such effective and powerful treatments to help reverse many of these ailments and conditions that they have. Now, how does bariatric surgery work? It's really important for us to spend a little bit of time talking about this, because in the wider population, people often think of bariatric surgery as an easy fix or an easy way out. People also think that bariatric surgery works primarily just by shrinking the stomach and reducing the amount of food that you can eat and drink. And whilst that's partly how it works, it's certainly nowhere near the full story. Quite often you'd hear people saying, well, if all you're doing is reducing the size of your stomach so that you're eating less, why don't you have the willpower to do it yourself? Or what's the difference between that and just going on a very low calorie diet? And the reality is that there is a big difference. When we compare two individuals, somebody who's had a gastric sleeve or a gastric bypass or a mini gastric bypass, to somebody who has just been on a very low calorie diet, we know that even though they might be eating the same number of calories, in reality, the person who's had the surgery will have more profound weight loss and more sustainable weight loss in the longer term. We know these very low calorie diets don't last or are not sustainable for more than a number of weeks before then people revert back to their old eating habits, and that results in significant weight regain. One of the things that we talk quite openly about is the fact that these types of treatments offer a different approach to weight loss. It gives us access to different pathways for weight loss as well. The sleeve gastrectomy and the gastric bypass, not only does it reduce your portion sizes because your stomach's smaller, but it also results in significant reductions in appetite and also changes to the pathway from the gut to the brain, which modulates and regulates your metabolism. So those changes in combination, and this is important, in combination with making the right lifestyle changes with respect to diet and with respect to physical activity, is what results in the significant weight loss and sustained weight loss in the longer term. Now, finally, one thing that is often overlooked is the importance of the brain space which comes along with some of these procedures. Quite often when I speak to people in clinic and I speak to them about how long they've struggled with their health and their weight, the overarching story is a daily struggle with their weight and a daily struggle or a daily unhealthy association with diet and food and yo-yo dieting and wondering which diet they're going to be doing this week and how much weight have they lost. And there's often a lot of background noise that comes along with obesity and struggling with weight loss and weight regain. And that can be quite heavily imprinted in somebody's psyche. If you can imagine over many years and sometimes decades, someone's been struggling with their weight, it's not unusual and it's completely understandable that there's often a lot of background noise with respect to the journey or their day-to-day life. What bariatric surgery offers is almost a clarity, because within that first 12 to 18 months that people have their surgery, people will lose a significant amount of weight. And that results in a positive motivation and a positive approach then to being able to move more freely because they're losing more weight. They're able to lose more freely and therefore able to engage in physical activity. And then in addition to that, the motivation that comes from seeing those positive changes also then leads on to healthier food choices. And that's primarily because when you put the effort in, you see the results. And that's often not been the case up to that point. The sleeve gastrectomy is the first procedure that we're going to talk about this evening. It is by far and away the most commonly performed procedure anywhere on the face of this planet. It was developed approximately 25 years ago, and initially was used as the first stage of a two-stage procedure. Well, actually what we found is by just doing that first stage of that procedure, just focusing on the sleeve gastrectomy, people were losing a significant amount of weight and were able to keep it off. The technique of the sleeve gastrectomy has certainly evolved and developed over the last 10 to 15 years, and that has enabled us to provide that as a standalone procedure, which is effective and results in sustainable weight loss when we, of course, combine it with some of those healthy lifestyle changes that we've talked about. The sleeve gastrectomy involves us removing part of the stomach, including the part that makes you feel hungry. So by doing that, we reduce portion sizes, we reduce appetite, and of course, some of those pathway changes, the links between the gut and the brain, that changes and results in changes in metabolism, which then will lead on to the profound weight loss. It's permanent. It results in us physically removing that part of the stomach. For most people, they can come into the hospital, they stay in overnight, they're home within, they stay in overnight, they go home the following day, and most people are fully recovered by about 2 weeks from a physical perspective. As you're probably all aware, and perhaps we'll talk about this in the Q&A session, the post-operative recovery in terms of the phases of diet, the fluid moving on to the pureed and then normal foods usually takes anywhere from about 6 to 8 weeks. The next procedure is something called the gastric bypass or the full gastric bypass. The full title, full medical title, is the Roux-en-Y gastric bypass. It is the gold standard procedure for bariatric surgery. It's the one that we've been doing for the longest. We've been offering the Roux-en-Y gastric bypass for over 60 years now. It started off as open surgery, of course, and it's been developed and refined over the decades so that we now are in an era now where the Roux-en-Y gastric bypass has been performed in a standard fashion for several decades, if I'm going to be honest. It involves making a small pouch out of the top of the stomach, no bigger than the size of your thumb. And then what we do is we cut part of the intestine, as we can see on the screen, and we join that to the stomach pouch. So the grayed out bit is the part of the stomach and the first part of the intestine, which is bypassed. So the food bypasses that part of the stomach and the intestine and the gastrointestinal tract. So the procedure works by reducing portion sizes because your stomach's a lot smaller, reducing appetite and hunger in a slightly different mechanism than that to the sleeve gastrectomy. It also results in those powerful changes to the pathways between the gut and the brain. And finally, because part of the food which is being consumed is bypassing part of the gastrointestinal tract, there is an element of malabsorption. So some of the calories that would have ordinarily been absorbed, or some of the foods and nutrients that would have been absorbed from the stomach or from the first part of the gut, that does not happen. So part of it is also a malabsorptive effect. Again, in combination with diet and exercise and physical activity, that results in significant weight loss. Finally, the mini gastric bypass or the single anastomosis gastric bypass is a relatively new contender in the field of bariatric surgery. It was developed around 10 or 15 years ago in the United States as an approach to make the bypass a less technically challenging procedure. So instead of having two joins, which is the case with the gastric bypass or the full gastric bypass, now what we're doing is only needing one join. And the other thing about this type of procedure is that the gastric pouch or the stomach pouch that we're making is a slightly different shape. You might notice when we compare the full gastric bypass on the screen that the pouch is small and it's short, whereas with the mini gastric bypass, the pouch is longer and narrow, and it's almost like a halfway house between a sleeve and a gastric bypass. Now, why is that important? Well, because the join that we're having to make is lower down, that means the tension that we create by bringing the bowel up to the stomach pouch is reduced. And often when we are faced with a scenario where a patient would particularly need a gastric bypass type procedure, and we'll talk about that in a second, then when somebody is larger and they need a gastric bypass procedure, it can be very challenging, technically challenging, and that then exposes people to a degree of risk, especially with healing, to bring up that bowel to the stomach pouch. Whereas in this scenario, it is easier to bring that bowel up to the stomach pouch, and therefore the complications rate should be lower in that particular scenario. Now, whilst it's called a mini gastric bypass, it is by no means mini. It's in its effect. It results in very similar outcomes and results to the full gastric bypass. And whilst this has only been around for 10 or 15 years, and certainly hasn't been very popular up until the last 5 or 10 years, and therefore we don't have longer term results, and that's one of the downsides of the mini bypass. Certainly the short and the medium term results are looking very positive. So let's now move on to some of the fears around bariatric surgery before we then move on to your questions. Number one fear is, am I going to die? And that is related to a broader concern regarding complications and risk. The first thing I want to reassure you is that the risk of developing a serious complication which results in death is actually very, very small. The risk is around 1 in 2,000. It's probably less than that. We know that figure quite accurately, certainly in the UK, because we all have to submit our data to a national registry, and that registry gets updated on a weekly basis and gets emailed out to the bariatric surgeons up and down the country. And in fact, I've only just received my report today, which I've reviewed. So these are accurate figures. When we compare that to, say, another procedure such as the cholecystectomy or removal of the gallbladder, or even having your joint changed or replaced, then we know that the risk of bariatric surgery is actually less than those other types of procedures. You may be shocked to hear. So it's actually a very safe procedure, and it's one that, of course, we carry out on a regular basis. The other risk that people worry about is the risk of leak. So the leak is the phenomenon which occurs when the staple line or the surgical joins that we make during our procedures, they don't heal properly. And what happens is your saliva and your food and drink then leaks out of that defect, and it can make you very poorly. If that happens, you will need additional treatment to fix that and sort that out. But the risk of that happening is very, very small. Now, there is an umbrella complication rate, which takes into account all other issues that can arise and that may need some additional treatment and investigation. And that usually is less than 5% for the gastric bypass and less than 3% for the gastric sleeve. People often worry about the amount of pain that they're going to be in. Well, you have to bear in mind that this is keyhole surgery. And as a result of that, we introduce gas into the belly in order for us to be able to see things a bit more clearly. That gas can irritate the diaphragm, can irritate the lining of the abdomen, and that can result in what we call gas pain. The other thing is, with respect to the wounds, we use keyhole surgery incisions, and therefore the impact of that is certainly significantly less than it would have been in the past when we used to do open surgery. As I've said before, physical recovery usually takes a week, but importantly, expectation is key. So whilst I've talked to you about some of the discomfort that you might have after surgery, you should also be aware that on the day of your operation, you will be expected to be up on your feet. you'll be expected to be drinking, looking after yourself, mobilizing to the toilet, such that the day after surgery, you should be then moving more freely, drinking more freely, and be ready to be discharged home. When you get home, it's not about laying in bed for the next 2 weeks. We want you up and about, hydrating yourself properly, reducing those risks of complications such as clots to the legs, etc., so that you can make a full recovery. Most people are back to work within a couple of weeks, and most people are driving within a couple of weeks as well. These are some of the typical incisions, certainly for my patients. People will have 4 or 5 incisions made, and this is commonly where I would make the incisions for my patients. In the recovery period, when we're talking about pain, there are certain expectations that you would want to see pain gradually reducing as the days progress. If you then develop sudden severe pain, either in the belly or in the chest, you must seek immediate and urgent support and medical attention. Now, another fear that people have is it going to work? What if it fails? And you can imagine that that is a really common fear that people have. And it's an understandable fear. As we've talked about before, you've had years and decades of up and down, yo-yo dieting, success and failure. In the psyche of somebody who's lived that journey and lived that experience, you will naturally have that fear of failure etched within you. And the key thing that you have to bear in mind is that everybody will lose weight with this surgery. However, the degree of weight loss that occurs very much depends on a number of factors, including the degree to which you adopt those healthy lifestyle choices that we talked about, your age, whether you're having revision surgery, and some of the other factors such as your physiology and biology. Let me just switch my phone off so that we're not disturbed. Okay. When we look at weight loss trends during the first 6, 12, and 18 months, the first phase, which is the rapid phase of weight loss, usually occurs within the first 6 months. Even within that rapid decline in weight, there will be ups and downs, so that there will be variation. And everybody's trend or pattern of weight loss varies significantly. So you may struggle with a stall where you plateau and you don't lose any weight for a couple of weeks. And that can certainly frighten people. Has the operation stopped working? Am I going to fail? Am I going to, is it going to get going again? I've invested so much time and effort in weight loss and going down this journey, and I've only lost so much weight. It's key to understand that these fears are really normal, and the stalls are also really normal. The other thing to bear in mind when we talk about success and failure, although I don't like to use those words, but success certainly isn't just focusing on the number on the scales at the end of the 12 or 18-month period, but you need to be judging success of these types of procedures in other terms as well. Has it resulted in an improvement into your health and quality of life? Has it resulted in reversal of a lot of the medical conditions that people complain of and have to take medications for? Not only do we have to think about weight, but look at measurements as well. Whilst you might be stalling, you have to realize that there are other physiological and biological changes undertaking during or happening in your body during that process. So you might be losing inches rather than kilos or pounds on the scale. So these are things that you need to be mindful of. The last thing that I would say is do not compare yourself to other people. Comparison is the thief of joy, as they say, and you are on your own journey. You have your own set of circumstances, your own genetics, your own physiology, your own commitment to making those lifestyle changes. And so naturally, the impact that those factors have will be relevant to you and not relevant to other people. You have to also bear in mind that not everything that you read online is true, and just keep that in mind. Focus on your own journey and your own path. And when you are anxious about things not going right, or you feel that you need some additional support, that is why we are here. That's the importance of aftercare and support from the dietitians, from the bariatric nurses, from the psychotherapists, and from the surgical team as well. People often worry about weight regain after weight loss. So it might not just be that they've not lost enough, but you actually lose enough and then begin to regain weight. And that's another fear born out of that yo-yo dieting cycle that we've seen over many years and decades in patients. The broad understanding is that if we take 10 patients who've had bariatric surgery, 7 out of 10 of them will lose weight, will keep it off for a sustainable, for the sustainable longer term. 2 out of 10 people will lose a significant amount of weight, but will also regain some of that weight. And 1 out of 10 people, we believe, will lose all of the weight and regain all of the weight as well. Now, that might be a shocking statistic, but it really does underpin and underline the importance of engaging with aftercare, making sure that we've addressed all the underlying factors which contributed to weight gain in the first place, so that they don't creep back in the future and cause you to risk weight regain. Having said that, some people will naturally regain weight, and there are now newer approaches to managing weight regain, which we can talk about later. The other concern is, are you ever going to enjoy food again? The short answer is yes, but you will be enjoying food in a slightly different way. We've already talked about the diet after your operation. You'll be going through liquid phase, pureed food, soft foods, and then normal diet, usually by about 6 to 8 weeks. But there are other considerations as well. Alcohol and fizzy drinks. Quite often people worry about them because they're being told, or they've read, that actually it results in stretching of the stomach, stretching of the sleeve, and that unfortunately is a bit of an old wives' tale. The reason that I don't encourage people to drink alcohol and fizzy drinks is they've got absolutely zero nutritional value to them. If you imagine you're going to have a very small stomach, your nutritional input is going to be significantly reduced, and therefore we need to prioritize good nutrition after surgery. That means good hydration. That means, in addition, prioritizing your protein, your fiber, your good fats and healthy fats, and then your complex carbohydrates in that order. If you do that, you're not going to have time or space for fizzy pop or drinks full of sweeteners and chemicals, or alcohol, in fact. In addition, with alcohol, we know that people are less tolerant of alcohol when they're drinking after bariatric surgery. So you not only will get more tipsy and drunk more quickly, but alcohol stays in the system longer than previously. So you need to bear that in mind. People can also develop new intolerances and differences in taste perceptions. And finally, let's talk about loose skin, because that's something that terribly affects people or affects people's decision-making process, and certainly is a big fear. Again, let me go back to expectations. Expectations are absolutely key. The more weight you lose, the more loose skin you're going to have. The older you are, or the more sun exposed you are, or if you're a smoker, you are more likely to have loose skin. The question that I always ask people in response to the question that they have of whether they'll have loose skin is having loose skin enough of a reason for you not to consider bariatric surgery or weight loss surgery, and the positive impacts that it will have? And the answer is almost certainly absolutely not. They're still happy to go ahead with bariatric surgery, but they just more want to be aware of what can they do to minimize the effects of loose skin. So some of these things that you should certainly focus on is make sure that you hydrate yourself well, make sure that you're taking your proteins and your multivitamins, making sure that you're building muscle to give your body a scaffold and some shape. We know, as we've talked about, you can't do anything about your age. You can do something about smoking, and you can do something about sun exposure as well. But the reality is that most people will have some loose skin, particularly in the NHS, where we tend to only put through people who are absolutely really struggling with their weight, and certainly have a higher BMI. So the more weight loss you've got to achieve, the more loose skin you're likely to have. The good news is, however, there is a remedy, or there is some treatment that you can have for loose skin, and some of these can be absolutely phenomenal. Some of these examples are placed on the screen here for you to see. Abdominoplasties, 360 contouring, certainly reconstruction of the chest, not just for women, but also for men. And of course, the areas under the arms and the thighs. You can really have a significant impact. What I would say to you is two things with regards to plastic surgery. Number one, well, actually three things. Number one, it's very rarely available on the NHS anymore, so you would likely have to fund that yourself. Number two, wait until at least 18 to 24 months after surgery to make sure that you have absolutely lost as much as you're going to wait, to make sure that you've lost absolutely as much as you're going to lose, but also to make sure that your nutritional levels have recovered and that your blood tests show that your nutritional levels are within normal limits. And finally, if you are going to go and consider plastic surgery, make sure that the person who you are considering, and you should certainly speak to more than one person, has experience in plastic surgery following bariatric and weight loss surgery, because the skin and the impact on nutrition results in a difference in the type of tissues. It can sometimes lead to an increase in infection rate, of wound infection rate, and you really need somebody with an experience in dealing with this subspecialty of contouring or plastic surgery after bariatric surgery. So in summary, weight loss surgery is really safe, it's effective, it is linked to some very, very small complications, but importantly, the benefits massively outweigh the very, very small risks associated with it. These treatments are absolutely life-changing. The biggest regret that people have when I speak to them is, I wish I'd have done it sooner. And, you know, that is really the echoing message that I want to put across to you, that these are life-changing treatments for people. And I hope that we'll be able to offer this as much as we can, as quickly as we can, to our patients, certainly logged in this evening. The final message is your expectations are key. You have to have realistic expectations, and that comes through engaging with aftercare, engaging with these types of webinars, but also engaging and reading and researching as much as you can, so that you know what to expect.
Once you come and see us, you'll see the surgeon, the medic and nurse dietitian have some further education and more conversations about which operation is suitable for you. And once you then get a date for surgery, which may be quite some time in the future, unfortunately, you will be started on this liver reduction diet. So the liver reduction diet does exactly what it says on the tin. Shrinks the size of your liver. So the liver is a big organ that sits in front of the stomach there, and making the stomach smaller just gives a better view for the surgeon. So it just makes it a little bit safer. So it's better for you if you follow this really well for those 2 weeks. So don't follow the liver reduction diet after the operation, and stick to it for two weeks. The surgeon might ask you to follow it for a little bit longer if you're a little bit bigger around the middle. They like to have a good view of the stomach, and we know that it's not just liver size that reduces, but body fat as well. So it makes the operation that little bit easier. So we know by following the liver reduction diet that this low energy, low carbohydrate diet effectively shrinks the left lobe of the liver, so it moves out of the way of the stomach. So just make sure that the surgeon can see that liver a little bit easier, and makes the operation safer, like I said before. So this is a liver reduction diet that you're going to be following. So we ask patients to follow a very low carbohydrate, low calorie diet. You can have 3 portions of carbohydrate per day, or 1 portion 3 times per day. Try not to save it up for any one meal. Spread it out through the day if you can. You can have 2 portions of protein, 2 of dairy, 2 of fruit, and unlimited non-starchy vegetables and salad to really make yourself feel full. So then there's an example on the screen there for you to look at, and we'll also give you examples and what 1 portion of each of those food groups consists of. So really important that you do follow that strictly for at least 2 weeks prior to your operation, maybe more if needed. Some people ask, can we do the milk and yogurt diet or the meal replacement diet? And yes, in theory you can. They still work by reducing your calories and reducing your carbohydrate intake. The reason why we prefer this low-calorie food-based option is because it gets you into good habits for after surgery by eating regularly and planning your meals. But also it gives you a little bit of real food and solid food and fiber. So it's going to help with your bowel movements after the operation. If you're on a liquid diet or a meal replacement diet for 2 weeks prior to the operation, and then you have the recovery diet afterwards, where you're going to be on liquids for a little while, then you're going to be on liquids for quite a long time, and that's not really good for anybody's guts or sanity. I don't think I would wish that on anybody, but some people want to do it, and that is okay. That's your choice, but this is the one that we would advise. So very small portions of carbohydrates spread through the day, a couple of portions of protein, lots of vegetables and salad to keep yourself feeling full. And that's one thing that I would say, is make sure that you utilize those vegetables and salad to bulk out your meals and make yourself feel full. On top of that, do try and drink plenty of low-calorie fluids. I know we're trying to shrink the liver, and it does that by reducing water in the liver and the muscle cells. But it's really important that you drink plenty of low-calorie fluid to keep yourself hydrated. A note of caution for the liver reduction diet is that if you take any medications for your diabetes that reduce your blood sugars, so certain drugs including insulin, for example, you would need to have a chat with us first, or your diabetes nurse, to adjust either the dose of your insulin or the other medication. If you have kidney problems that require you to have reductions in your fruits, vegetables, or dairy or protein, then you need to let us know, and we can come up with a suitable alternative. But other than that, you should be okay to follow the liver reduction diet. But any problems or anything like that along the way, you can contact us. After the operation, we put you on a recovery diet for 2 to 3 weeks on each stage of liquids, puree, and soft. And this is basically just to make sure that you recover really well, get you used to eating food again without making you sick. So gradual progression through the stages. Don't rush. If you are struggling at week 2, please kind of go on for another week on that stage until you feel ready to move on to the next stage. So yeah, 2 to 3 weeks on each stage, and you've got different operations on there. Bands we don't do so much anymore. I'm sure you've heard from surgeons in the past on this channel that we don't do bands very much anymore. We take out far more than we put in. Most common are the sleeve and the two different types of bypass. So regardless of either of the two types of bypass or the sleeve, you'll be following the same recovery diet. So your liquids start on day 1 after surgery. So you're talking 30 mils of water to sip per hour until the team are happy with you. Then you can move on to sips of free fluids, including squash and tea and coffee and milk. And then you move on to a normal liquid diet, where you'd be having fortified milky drinks, you'd be having smoothies, you'd be having protein shakes, soups, etc. And there's an example day on the right hand side there for what you might be looking at. You're aiming for at least 2 liters in total per day, or 1.5 to 2 liters. But that includes all of your liquids, including the soups and smoothies and protein shakes and water. Make sure that you take really small sips frequently and avoid anything that's too fizzy. And we ask you to avoid alcohol for 6 months after your operation as well. So no alcohol and no fizz. The next stage is puree. And this is kind of the stage where you're introducing food in small amounts without making you feel sick. It should be nice and smooth, like baby food. And you don't have to have a pureed meal at each meal, as long as you're having some puree, just to get your body used to introducing a new texture. You're learning the way your stomach, your new pouch works, and what will work for you and what won't, what will go down and what may make you sick, and learn your eating habits. So really important that you have these smooth consistencies in small portions spread throughout the day. And again, there's an example meal plan on the screen there that you can see, and this is all in the written information that you'll get as well. When you start in the puree, just make sure that you really practice those eating habits that we're going to talk about in a second. So even though the pureed stage doesn't really need chewing as such, please still do so to practice. If you put too much in your mouth, even of the puree, you'll end up being sick. So it's really important that you take small bites, you chew well, you separate your eating and drinking, and you stop when you've had enough. The next stage is a soft diet. So this is the soft fork mashable stage. And again, 2 to 3 weeks on this stage, similar kind of foods, but you don't need to blend them down anymore. So again, moving through different levels of building up the textures, as you can see on the screen there. So after 2 to 3 weeks on the soft stage, gradually building up textures, you'll be back to full normal diet. So within 8 to 12 weeks, you should be back to normal consistencies in very small portions. So we want you to be eating healthily with small portions, planning to have your meals and snacks regularly throughout the day on small plates, making sure that you get the right kind of balance and consistencies at your meals, using lots of crunchy, solid, challenging textures to keep your portions small, focusing on the protein and the vegetables and things like that at your meal times, and keeping the carbohydrate intake small, remembering your eating habits, obviously. And at this stage, really important to note that it's the quality of the food that you're looking for, not the quantity. So make sure that your food is nutritious and healthy and balanced, plenty of color, plenty of fiber, plenty of protein, and that should help to make sure that your weight loss continues, your weight doesn't go back up, and you're feeling satisfied from your meals. So there's an example plan of a normal day, what it might look like. So you can see there's 3 meals and a few sensible snacks throughout the day. On top of that, you need to be drinking plenty of low-calorie fluids again, and ensuring that you separate your eating and drinking. Eating habits, really, really important. I can't stress enough how much that I would kind of recommend that you practice the eating habits prior to having bariatric surgery. It's a shock to a lot of people how much you have to chew things and how slow you have to eat, and the change in your approach to food. So do develop it early on, start from now, practice your eating habits. So we have this rule of 20. So 20 pence piece sized bite, chew it 20 times, put your knife and fork down for 20 seconds, stop after 20 minutes. So it's really small bites, you chew it thoroughly, you have a break in between each bite, and you don't eat for more than 20 minutes. And that just gives your body a chance to kind of digest the food, let it go into your new pouch and through into your small intestine without causing you any discomfort or end up being sick. So really important also to separate your eating and drinking, maybe 20 minutes before, 20 minutes after, aim for that and see how you get on. Other things on there: stop when you've had enough, and don't return to leftover food. So that's a predictor of weight regain, which we will come on to later on. So a brief overview of the liver reduction diet and then the post-op recovery. And then once you're back to normal foods, you can start the supplement regime. So you are going to be on a complete multivitamin and mineral supplement, some iron, some B12, calcium and vitamin D, and the folic acid is already in the multivitamin. You may need extra, but you will be taking some supplements for life. And these are to prevent deficiencies rather than to treat anything. If you are low in anything at any point, then we can give you some extra advice, or write to your GP for their input and increasing or decreasing the dose of the supplements. These are the vitamins and minerals normally are contained in your multivitamin, but some people do have low levels further down the line, so we just recommend routine monitoring annually via either your GP or via our medical weight management service. So I hope that has been useful from a brief kind of overview of the diet before and afterwards. I can see there's a fair few questions on the chat, and we'll get to them later. But I thought I would answer a couple of the commonly asked questions that come in. And one of the most common ones is, how much protein do I need to consume? And that is it's a difficult question to answer, because we work it out in grams per kilogram of ideal body weight. So as you can imagine, that's different for everybody, and it's really quite difficult to achieve. However, our guidelines, they've started from America, but the British Obesity Metabolic Surgery Society also support the 60 to 80 grams of protein per day. So anywhere in that target would be ideal. Gentlemen probably need a little bit more than that, a minimum of 80 up to kind of 90. That's what we're aiming for. Like I said before, it is quite difficult to achieve, especially as some people have intolerances to meat and fish, or they're vegetarian, they struggle with dairy products, etc. So it can be quite challenging to meet that 60 to 80 gram per day target. So a lot of people do ask if I consider protein supplements a good option. Now, I never used to, but I think they are becoming more available, a lot cheaper, more tasty, and less additives in there from over my career. So I think they are a good option. So there are lots of good sources of protein. So there's some examples there of when you're on the liquids, when you're on the puree, when you're on soft, and then the same kind of foods when you're back to normal. So yes, we first line is to use the milk and the milk powder, because it's probably the cheapest way of getting your protein in. A pint of milk with 4 tablespoons of milk powder added will give you about 40 grams of protein. So that's equivalent of around 2 protein shakes, something like that. If you drink that through the day, it's kind of 2/3 to half of what you need, and then you can add high protein soups, or high protein smoothies, or another protein shake throughout the day. Definitely protein shakes, protein waters are more common, and I've got no problems with you using them, as long as they're no added sugar and there's no other additives that you don't necessarily need. So it should just be a plain whey protein, or a whey protein water. So I hope that answers that question. One more thing to add on that is that with time, I would like you to come off the protein shakes and protein waters and anything that's too liquid in terms of protein. In the long term, I want you to be getting your protein from solid food rather than from liquids, and that's going to help to keep you feel full, and that will help with long-term weight loss and weight maintenance, and preventing weight regain, which we're going to come on to shortly. Leading on from that is, how many calories do I need to consume? And again, this is worked out using gender, age, height, and weight. So it's different for every single patient. And if I work out everybody's calorie requirements after surgery, nobody meets them. So your calorie needs are way higher than anything that you're going to achieve. So that's why we don't kind of recommend a calorie target to start with, because some people are, really low and building up gradually. Other people are a little bit higher and can manage a little bit more. So from my experience, the calorie intake in the first few weeks after surgery is vastly different from person to person, depending on their nausea, their food choices, their taste changes, how they're getting on with medications. It's very, very different. So I don't really like setting calorie targets, because I don't want to unnecessarily worry people. I would rather have one-to-one conversations with patients, and give them the support that they need from that perspective. So instead of focusing on the calorie intake, what I ask patients to focus on, these are the patients maybe a little bit further down the line, when they're recovered from their operation and they're 3+ months onwards, is to focus on the basic principles of bariatric nutrition. And what I mean by that is making sure that you eat regularly. So having your 3 meals per day, and maybe 2 to 3 snacks if needed. You might need to plan ahead to achieve that, make a menu at the weekend and do your shopping. that will all help with that. So definitely regular eating pattern does help. Patients that skip meals aren't going to be getting enough calories. So in effect, that might be leading to too much weight loss, or it might lead to a stall, because often when patients don't eat enough calories, they consume more later on, and actually they're tired, they're more tired, so they move less, they're more hungry, so they snack more. So yeah, to make sure that you eat regularly. Prioritize your protein, so looking at a quarter to a third of your plate covered in protein, so whether that be from meat, fish, corn, pulses, eggs, all those good sources of protein. Make sure each of your meals has a good source. Make sure you're getting plenty of vegetables, so 3 or more portions of vegetables and a couple of portions of fruit. Looking at covering about half of your plate with veggies or salad. So getting plenty of fiber and plenty of crunch and plenty of colour. And if you can still manage a little bit more, you can have small portions of low glycemic index carbohydrates. So what I mean by that is things like whole grain pasta, whole grain rice, if you can tolerate it. Things like sweet potatoes with the skin, white potatoes with the skin, all those are really good low GI carbs to include, but obviously in small portions. Like I said before, try choosing solid, challenging textures to keep that portion small. We know that soft foods can be eaten in bigger portions and can lead to weight regain. So making sure that you can focus on more solid, challenging things, and drink plenty of low-calorie fluids and avoid grazing, which we'll come on to in a minute. So although I know I've said that I don't really like to give calorie targets, some people really do like to have that there. So as a guide, that initial recovery diet, you're aiming for 600 to 800 calories. In the first year, you're probably between 800 and 1200, and then in the longer term, it's 12 to 15. But some people do go a little bit higher than that, and as we'll see, some people actually go a lot higher than that. So I hope that helps to clarify, the calorie targets and why we don't really set them. And why the other things are more important than just focusing on the calories. I do find that if patients meet their protein requirements, they meet their fruit, vegetables, and salad, they're getting plenty of low GI carbohydrates and some dairy products. If they're doing that and they're eating regularly, they're not going to be exceeding their calorie intake. They can't be. They're going to be too full. So yeah, hopefully that helps. So weight regain after surgery. So we now know that weight regain is actually expected after bariatric surgery. So, but only a small amount. So about 70% of patients will reduce their weight by their 60 or 70% of excess, whichever operation they choose to have, and then they will kind of regain a little bit and then stabilize, and they will stay there for the long term. So that's what we're aiming for. So don't panic if your weight goes up a little bit and then stabilizes. That's to be expected. That's your body just settle into its new normal pattern. So yeah, don't worry about that. That's what we're aiming for. I often find patients that do get to that point and stabilize, they often want to lose another stone or two, but I advise them just to aim for stability and think of other non-scale benefits. So don't just focus on the number on the scales, but focus on other things that will keep you motivated. I find that people that get to there, that really push themselves to lose that extra stone or two, they become despondent. So they because their calorie intake is too low, they become tired, fatigued, they don't want to exercise, they become more hungry, and then they end up putting the weight back on. So that despondency just creep in, and then sometimes the weight goes up even further. So once you're at that plateau, I would advise you to kind of aim for stability. Unfortunately, 20% of patients may gain a significant amount. So they lose weight and they come back up, but not gaining all of it. So they've still got some benefit from the surgery. And unfortunately, 10% of patients may regain all of their weight, or not lose enough weight initially. But it's difficult to tell who's going to lose what and who's going to regain what and why. But the reasons why people regain weight after bariatric surgery are the same as the causes of bariatric of obesity in the first place. Sorry. So we know there's lots of causes of obesity, from kind of education and environmental factors, social factors, lots of things going on that cause this chronic condition. And we know it's a chronic condition. So we know that bariatric surgery doesn't cure obesity, but it's a tool to help kind of control it. And unfortunately, some patients, it's not effective, and weight goes back on. So there's lots of things there that can go back on. So you might start on a new medication, you might develop a new illness, something might go on in your social life, you might end up working nights, and that affects your dietary patterns and your sleeping habits, etc. So you've got to look at this as a whole. Do you need to change your job, for example? Do you need to look at other forms of employment? Do you need to kind of get new support from different family members, etc.? But from a dietary perspective, there are real kind of things that stand out from my experience of patients that are regaining weight, and I've listed them there. So eating patterns, like I said before, patients that don't eat regularly end up putting weight back on because they can go back into old habits of over restriction and overeating, and that can lead to weight regain. So getting into a good habit of eating regularly early on is a really good good baseline. Getting the right balance at your meal times, like we said before, about focusing on the protein, getting lots of vegetables and salad and small portions of low GI carbohydrates, and looking at the food texture and the food quality. So rather than going for soft, sloppy slider options that are going to leave you feeling quite hungry quite soon after you've eaten, or they can be eaten in bigger portions, we want you to be looking at more kind of healthy, balanced, challenging, fibrous foods to keep those portions small. Some people have too much energy from liquids, so they might drink a couple of litres of milk. They might have sugary fizzy drinks. It might be a litre of pineapple juice. Just trying to think of some of the things that I've come across. Alcohol intake might increase as well. So all this energy from liquids that are going to just slip by the operation, and not make you feel full, and just create an excess of energy, and your weight goes up. Grazing is probably one of the biggest predictors of weight regain. So that, what I mean by grazing is continuously nibbling. So although we want you to be eating regularly through the day, we do want you to have defined meals and snacks. So what I mean by that is, if you're having a snack in between your meal of, say, an apple and some peanut butter, then I would like you to eat that over 15 to 20 minutes and stop when you've had enough. So you might be able to manage half of the apple and a tablespoon of peanut butter, and that would be you finished. Grazing, on the other hand, would be kind of picking at a fruit bowl over the morning, or going for biscuits dumped in tea that you can just kind of keep going back to, nibbling on things like nuts from a packet rather than just having a measured portion, or even going back to meals afterwards. So having a couple of mouthfuls, doing something, then going back to it later, having a couple more mouthfuls, stopping and going back to it, and kind of stretching it out over maybe an hour or two. So you've eaten the same portion, but kind of spread it out over a longer period. And also head hunger, comfort eating, boredom eating. These things don't go away after surgery unless you really put the effort in to manage them. So definitely go to the food and mood groups with your kind of tier 3 or weight management provider, and that would help. But there's lots of things that we can help you with in terms of that in the long term. And you're not alone in any of these things. The number of times that we come across these dietary patterns creeping in is quite frequent. So we do have support groups and things that you can access afterwards. But talking about preventing regain, This is where those dietary habits really come in very important. And you've got to use the surgery as a tool to help you develop these healthy habits from the start. So the meal planning, the textures, the healthy, well-balanced meals, the healthy snacks in between, the not grazing, the avoiding comfort eating at night, things like maybe doing some exercise if you're particularly stressed and you're a comfort eater, things like that. You've got to start those early on and carry on as you mean to go on. Start as you mean to go on, sorry. And I've put on there just to follow the basics like we've already gone through today: regular eating, good quality nutrition, avoid the sliders and the grazing, but allow occasional indulgences. So still allow yourself to have a treat on occasion. That's absolutely fine. That's normal healthy eating and human behavior, so that's absolutely fine. It just can't be a regular thing. Developing new relationships with food in terms of eating habits and shopping habits, and the way you approach your nutrition plan for yourself and your family. We see real benefits across the whole family from these operations, from learning about portion sizes to healthy eating to regular eating patterns, etc. So if you can get your children involved and work on it together, that would help the next generation as well. So yeah, think outside of the box and how it can help everybody. Another thing to help prevent regain is to set some goals. So set some goals, but think of non-scale goals, non-scale benefits. So not just I want to be 10 stone by this time next year. Sure, that's a good goal to have if that's something that you want to achieve. But thinking of other things. So maybe going on a roller coaster, or going on an airplane without the extension seatbelt, or anything like that really. So some non-scale benefits, maybe doing a 5K walk, or climbing a mountain, or something other than just getting on the scales and seeing what you weigh from day to day. Do attend our follow-up. So please, if you get missed for whatever reason, you still want to come for follow-up, then please do give us a call and let us know. We don't miss anybody on purpose. So if we don't offer you an appointment, then please do get in touch and attend your follow-ups. If you notice that you're regaining weight, then please get in touch even quicker. So it's easier to put things right early on rather than leaving it too late. Don't be embarrassed. It's not something to be embarrassed about. We know that, I said before, obesity is a chronic condition that does relapse. So it does happen, and we know that. So do seek help early and be honest with yourself about the reasons why you're gaining weight. If you're honest with yourself and you're honest with us, we can help you. And also seek support outside of the follow-up team. So friends, family. There's lots of things on social media that I'm sure that you're all aware of or involved in. I try and stay away from it, but yeah, there's lots of things on social media.
My name is Raisa, and like Jodi has mentioned, the purpose of this presentation is just to give a bit of an overview about the role of the pharmacist and in their responsibility in taking care of the bariatric patient. So the things I'm hoping to cover in the presentation is just a bit of talk about pharmacokinetics, the different types of bariatric surgery and the resulting changes to the anatomy, the impact that will have on the medications, some of the factors that we need to consider as a result of that, a little bit about supplementation, and just what you would expect to see to be discharged with when you undergo surgery, and then finally get the opportunity for questions. So what happens to medications after you take them? So very simply put, this is a study of pharmacokinetics. So it's exactly what the drug does to the body. So when you take medications, it undergoes numerous processes within the bodies in 4 stages. So absorption, so it's absorbed. So there's different sites of absorption within the body. And the stomach is one of the primary sites of absorption, as is the small intestine. So after absorption, the target is the bloodstream. So after the it gets it within the circulatory system, and it then gets distributed within the body to the different parts to the different organs and where it needs to go for its site of action. It then undergoes metabolism, and the liver is the most common place where this will occur. And then finally, the medication is excreted from the body. So all drugs will undergo these phases and will have different pharmacokinetics. So a sleeve gastrectomy, so the picture on the left is what would be the resulting anatomy after you've undergone a sleeve gastrectomy. So what that results in is a loss of absorption site of the stomach. But what's important is that with the sleeve gastrectomy, you do retain all of the small intestine. With a gastric bypass, the resulting anatomy results in much smaller stomach size, and the absorption is significantly reduced, and it will bypass the duodenum completely, which is part of the small intestine. So what these resulting anatomical and physiological changes means that the stomach size is going to be drastically reduced. So this means that the primary area for disintegration, so when you take tablets orally, you need to give it time for it to disintegrate. And quite often, in order for it to disintegrate and then, get absorbed and get into your bloodstream, that happens in your stomach. So after surgery, we need to consider that the stomach size has decreased. The other big change is the fact that the pH within the pouch that's created after the surgery is much higher than that's found in a normal stomach. And then the surface area is also reduced within the GI tract. So there's less surface area for the drug to be absorbed in after surgery. What impact will that have on the medications? So with the stomach size being reduced, there's restricted size, and therefore you're not going to get, there's a chance of the medication not being completely disintegrated. With the increase in the pH, a lot of medications are soluble and in an acidic environment, so they rely on the acidic pH noted within the stomach. Some medications are absorbed and are soluble in an alkaline environment, which means that they will be absorbed in the small intestine, but that's bypassed in a gastric bypass. So that's, again, these things we just need to consider with medications. And finally, drugs which require longer transit times to undergo their absorption are likely to have impaired absorption, because we're going to have a reduced surface area for them to work with as well. So what are some of the things that we need to consider, and what recommendations do we normally make with the medications? So the first big one is that immediate release formulations are preferred. So any medications that have an MR or an XL next to them means that they have a modified release or an extended release, meaning that they are given much longer time for it to release its content as it goes slowly throughout the GI tract. So we avoid these types of medications after the surgery. Any enteric coated, so like GR resistant, again, can also be quite problematic, because this means that it's absorbed a lot further down, and in patients post bariatric surgery, there's much less GI transit to work with. So we try and avoid these kind of medications as well. Effervescent formulations, so sometimes just in the immediate kind of post-op period, due to discomfort, effervescent drug formulations are best avoided. So we want to make sure that the tablet is fully dissolved and allowed to settle before drinking. So we also monitor the patient. So we're really lucky in that a lot of the medications after surgery, we should be able to monitor to make sure that they are still quite effective. So for example, if you're on a tablet for hypertension, for high blood pressure, and you take that medication, in order for us to see that it's still being absorbed and it's still being effective, we can just keep an eye on the blood pressure. Similarly, if you're on medication for pain, for heart rate, all sorts of things, normally if we just want to see that it still produces the intended effect after surgery. So we won't necessarily make all changes. We'll sometimes, quite often, just make sure that we kind of keep an eye on it and monitor it. The other thing to consider is that the openings after the surgery are very small. So about 1 to 1.5 centimeter wide for things to for intake to pass through. So we just need to bear that in mind, because certain medications are bigger than 1 to 1.5 centimeters, and so those medications will need to be changed. So the alternative drug delivery routes that we want to consider would be liquid formulation. So if absorption is reduced, a liquid preparation or an alternative administration route may resolve the problem. So you can consider crushing tablets when appropriate, but so that's an option. We can open up the capsules and dissolve the contents in water. In practice, we don't often always switch all medications to liquid formulations, and that's because we're trying to avoid dumping syndrome. So if we give, especially in the kind of acute period after the surgery, if we give a lot of liquids, that can be quite uncomfortable for the patient. So in medications where we have to take liquid, we try and aim for sugar-free liquids, and we advise to sip slowly. There's other routes of administration, such as patches or subcut medications if needs be, but these are, again, it all depends on what medication you're already off, and they'll get a thorough review and only switched if needed. So I thought I'd talk just a little bit about the nutritional deficiency. So bariatric surgery impacts both oral intake and absorption, which puts you at increased risk of nutritional deficiencies. So there's a chance of because of the fact that you're not going to be able to take as much orally, there's a chance that you're going to be prone to fat-soluble vitamin deficiency, so vitamin A, D, E, and K, calcium, iron, vitamin B12, and folate. So following all our bariatric procedures, we normally recommend that you get started on a multivitamin and mineral supplement. So the minerals are quite important. So these contain the thiamine, minimal amount of iron, zinc, copper, and selenium. If you've undergone a sleeve gastrectomy or Roux-en-Y, we also recommend taking additional iron on top of what's already included in the multivitamin, and vitamin B12 as well. So the reason that you need vitamin B12 is that there's a protein called the intrinsic factor, which is produced in the stomach. And as a result of after the surgery, with the reduced stomach size or the bypassing of the stomach, it's going to have an impact, because it's needed in the body's role to absorb vitamin B12. So if you're not able to have as much of that intrinsic factor, you won't be able to have as much vitamin B12 because you won't absorb it. Which is why we also recommend that you have every 3 months an IM injection of vitamin B12 to ensure that you don't become deficient. You will also, if alongside this, obviously this will provide, it won't be treatment doses of vitamins, it won't be treatment doses of the minerals. So if you are found to have any deficiencies, it is important that we treat the deficiencies. The post-op medications that you'll get started on. So this is a list of the post-op medications that you'll get started on. So the first one is a blood thinning injection. So surgery puts you at risk of developing a blood clot in the veins. So as a result of that, we always send patients home with a blood thinning injection. The dose that you will have and how long you'll have depends on you. So it depends on your risk factors beforehand. It depends on various things. So it'll be patient specific, those two, how long you take it for and what strength you take. The second thing that we always send patients home with, and we want to be mindful, is something to manage their pain after the surgery. So quite often it would be liquid paracetamol and codeine tablets. But this is somebody that, for example, wouldn't have been on any medications to manage their pain, or doesn't have any comorbidities or conditions that requires them to take anti-inflammatories or any kind of medication, pain management medications before the surgery. The third type of medication you'll be started on are lansoprazole. So that's different centers use different PPIs. So what PPIs stand for are proton pump inhibitors. So because of the new joining that's made after the surgery, there's a chance that ulcers can form at that new joining. So to prevent that and to reduce the acid in the stomach, we start patients on proton pump inhibitors, and that reduces the acid in the stomach. So we tend to give lansoprazole dissolvable tablets, 30 milligrams twice a day, which we advise to take for 6 months. And then after that, you can reduce it to just once a day. Different centers will advise different things. This is what we currently use. So this is in the kind of post-op immediate period. After that, you will be started normally 2 to 4 weeks. You'll be seen by the dietitian, and you'll be seen by the specialist bariatric nurse, and you'll be started on, or that's when you will be started on the oral vitamin and mineral supplements for life.